aspirants and our honorable faculty. Today's speaker, the class is Dr. Varun Arora. He will take a lecture on Gillian Barre Syndrome, and he is a consultant in surgical ICU at Rajiv Gandhi Cancer Institute and Research Center, ROHINI in New Delhi. His area of interest is in septic shock, advanced hemodynamic monitoring, ARDS, and antibiotic stewardship. Welcome to this class, sir.
Good evening, everyone. The topic which I'll be taking today is, I'll pronounce it as Gillian Barre Syndrome. My name is Dr. Varun Arora and I'm a consultant in Rajiv Gandhi Cancer Institute and Research Center at ROHINI, Delhi. So, when I gave my EDIC part 1 5 years back, I still remember that I got 2 questions from Gillian Barre Syndrome because we discussed it after the exam. So, I presume that it is very important topic, and even in the MCQ test books, we usually get 1 or 2 questions in every question paper. So Guillain-Barré syndrome is the most common and most severe acute paralytic neuropathy. Although it is rare, but it is potentially fatal, immune-mediated disease of peripheral nerves and nerve roots. It affects nerves of both brain and spinal cord. All the cranial nerve and peripheral nerves got affected. There is exposed nerve fiber, damaged myelin sheath over the nerve fibers due to deposition of the immune complexes. This syndrome is rapidly progressive and runs a monophasic course over 4 weeks. It usually occurs 2 to 4 weeks after respiratory or gastrointestinal illness and is caused by a variety of infectious agents, or nowadays it is usually also seen after vaccination, especially after COVID vaccination. We have got certain case reports. However, only 2/3 of the adults will have history of infection. Rest 1/3 will not give any history of infection. Symptoms usually peak within 4 weeks, followed by a recovery period, which lasts from months to years because the immune response decays and peripheral nerve undergoes endogenous nerve repair. Now in this graph, you can see there is infection of 1 to 2 weeks. When this infection wanes, there is antibodies to gangliosides. These antibodies are usually produced against these microorganisms, but these antibodies, they target the gangliosides which mimic the antigen of these microorganisms. So there is progressive rise in the serum antibodies. Once the antibody starts waning, we can see the nerve damage and there is progression of the disease, followed by plateau phase and recovery phase. The list lasts from months to years, followed by disability, which we see in 20% of the patients. The incidence of Guillain-Barré syndrome is 1 to 2 per 1 lakh population per year. The incidence rises with age, and there is a 20% rise with each passing year. It is slightly more common in males. The ratio which we see in articles and recommendations is 1.74:1, almost twice as to females. The frequent incident symptoms in Guillain-Barré syndrome and related disorders include fever, which is seen in 52% of the cases, cough, sore throat, nasal discharge, and diarrhea. Various microorganisms are associated with Guillain-Barré syndrome. The most common is Campylobacter jejuni, which we see in 20 to 25% of the cases. Others include cytomegalovirus, Epstein-Barr virus, herpes simplex, mycoplasma, chlamydia infections, and also HIV, which is associated with very few cases of Guillain-Barré syndrome. Recently, we have seen that after vaccination, especially with H1N1 and COVID vaccination, we have seen certain case reports of Guillain-Barré syndrome. The other vaccinations include hepatitis B, tetanus, and rabies. This syndrome is associated with 3 to 5% mortality, and ventilatory requirement is seen in 20 to 30% of the patients. Therefore, we should have a very high index of suspicion that a patient with Guillain-Barré syndrome can go into respiratory failure and ultimately require ventilator. Severe disability, as I have already told you, is seen in 20% of the cases at 6 months. There are various variants of Guillain-Barré syndrome. The most common is AIDP, that is acute inflammatory demyelinating polyneuropathy. AMAN, acute motor axonal neuropathy, or AMSAN, acute motor sensory axonal neuropathy, is common in certain parts of the world like China and South Asia countries. It is more common after this Campylobacter jejuni infection, and we see antibodies to GM1, GD1A, and GD1B gangliosides in these two variants. Miller-Vision variant, we see a triad of ophthalmoplegia, areflexia, and ataxia. And in 85 to 90% of patients with this Miller-Fisher variant, we see anti-GQ1B antibodies. Now, there is one term known as Bickerstaff brainstem encephalitis. It is similar to the Miller-Fisher syndrome. That is, we see ophthalmoplegia, areflexia, and ataxia, but with encephalopathy and hyperreflexia. See, in all the other variants of GBS, we usually see hyporeflexia or areflexia. But in this Bickerstaff brainstem encephalitis, which is very, very rare, we see hyperreflexia. The other variants of GBS include acute pan dysautonomia, pure sensory GBS in which we don't see any motor weakness, facial diplegia and distal limb paresthesia variant, and there is one variant where we see pharyngeal cervical brachial weakness. So how to diagnose the case of GBS? The key presenting symptom in most of the cases is rapid onset of symmetrical weakness within 12 hours to 1 to 4 weeks with loss of deep tendon reflexes. The reflexes can be initially normal, especially in pure axonal or motor forms, and even be hyperreflexes in few cases. So loss of DTR is not a specific sign of Gillian Barre syndrome, and you can see normal reflexes also and even hyperreflexia. This is one of the questions which we commonly encounter in MCQs. The other manifestations include altered sensations, numbness, tingling, or pain in the affected limbs. Diagnosis of GBS is purely clinical, and there are no diagnostic biomarkers as of now. So why CSF examination is important? It is to exclude the other cause of weakness associated with increase in cell count like meningitis. So in this case of GBS in CSF, you see albuminocytological dissociation. What is albuminocytological dissociation? It is elevated CSF proteins with normal cell counts, usually less than 50 cells per microliter. Normally, we see 0 to 5 cells per microliter, and even if it is less than 50, we usually consider it normal. CSF proteins are normal for first 44 hours, and then they start increasing, and usually they peak after 1 week. In 75% of the cases, we see that the CSF proteins have peaked after 1 week. So it is very, very important to know that normal protein level does not either make a diagnosis or exclude the GBS in a patient. Now next are the electrodiagnostic study, the NCV and the EMG. As I have already told you, diagnosis is purely clinical, but nerve conduction studies are there to help support the diagnosis and to differentiate between the two commoner forms of the GBS, that is axonal or demyelinating forms, and for prognosis. NCV, the nerve conduction velocity will show slowing, or there will be conduction block in 80% of the cases. Patchy reduction in NCV less than 60% of normal. In axonal forms of GBS, there will be decreased distal motor and or sensory amplitudes. H reflexes may be absent and F responses may be prolonged. These electrodiagnostic studies will be normal in 15 to 20% of the cases, so they are not helpful for the diagnosis. In a case of typical GBS, what are the diagnostic criteria? The essential features of such a patient will include progressive weakness, symmetrical progressive weakness of legs and arms. There will be bulbar and facial involvement and external ophthalmoplegia. And you will commonly see areflexia, that is loss of deep tendon reflexes. The other supportive features which may not be present in all the patients include progression of symptoms over days to weeks, There will be relative symmetry of weakness in both the limbs. Mild sensory symptoms or sign will be there. There can be cranial nerve involvement, especially bilateral facial nerve weakness or bulbar involvement. Patients can have autonomic dysfunction, which we will see later. Most of these patients have pain. On CSF examination, there will be albuminocytological dissociation, elevated protein with a cell count of less than 50 cells per micrometer, and typical electrodiagnostic features which I have already described. Now, features that raise doubt about the diagnosis of Guillain-Barre syndrome in a patient. If a patient has severe pulmonary dysfunction with limited weakness at onset or severe sensory signs with limited weakness at onset, then you can have doubt about the diagnosis of GBS. If there is bladder or bowel dysfunction at onset or fever at onset, or if there is a sharp sensory level below which we don't have any sensations, if there is a slow progression with limited weakness without respiratory involvement, then we should consider that the patient have either subacute or chronic inflammatory demyelinating polyneuropathy. If there is a marked persistent asymmetry of weakness, usually in a GBS we see symmetry of weakness, but if there is an asymmetry of weakness, then there is doubt about the diagnosis of GBS. If there is persistent bladder or bowel dysfunction, then also you should suspicion a doubt about the diagnosis. If there are increased number of mononuclear cells on CSF examination, or if there are polymorphonuclear cells in CSF, then suspect meningitis rather than GBS. So let's see the pathogenesis. Whenever there is an infection by Campylobacter jejuni or any of the microorganisms which I enlisted, the body generates an immune response and produces antibody. These antibodies, because they mimic the gangliocytes, they cross-react with the nerve cells, the outer membrane, the LOS, lipo-oligopolysaccharide, or the exolemma of the nerve cells. And we see two common variants. First one is the AIDP, which is the commoner, seen in 85% of the patients. Acute inflammatory demyelinating polyneuropathy. So there is demyelination of the nerve sheath, the Schwann cell. And in this acute motor axonal neuropathy, the complements get activated, the macrophage recruitment is there, formation of membrane attack complex, and there is damage to the axonal sheath and the nodes of Ranvier, not to the outer Schwann cells and myelin sheath. Now only few people, less than 1%, someone's mic is on. Please switch off the mic. Thank you. Now only few people with infection to the Campylobacter jejuni will demonstrate GBS, less than 1%. They will only mount the specific humoral antibody immune response that can develop into GBS. So let's see why only few people develop neuropathy after infection, not all. There are two reasons for this. The first reason is only small proportion of these bacterial strains have ganglioside mimics, not all. Most strains bear other glycans. So that's why this is one of the reason. And the other reason is most individuals maintain an immunological tolerance to the self-glycans on outer membrane and mount a response to other components of the bacterial surface for killing of the bacteria. Why they lose this tolerance, that is still a matter of research. So these two reasons are there, that not everyone who gets infected with Campylobacter jejuni develop GBS, and the incidence is less than 1%. No, approximately 50% of the patients reach their nadir of the clinical course by 2 weeks into the illness, 80% by 3 weeks, and almost all by 1 month. So that is why the course of illness usually lasts from 1 week to 4 weeks. Progression of symptoms beyond 4 weeks, but arresting within 8 weeks, that is 2 months, has been termed as subacute inflammatory demyelinating polyneuropathy. And if it persists beyond 2 months, it is designated as chronic. A small percentage of patients, 2 to 5%, have recurrent GBS. Now, there are three major treatment issues. The first one is when to intubate to control the airway and to respiration. This is the most important. To recognize and to effectively manage the autonomic dysfunction is the second major issue. Third major issue is to effectively treat the GPS by administration of either plasma exchange or intravenous immunoglobulin in suitable candidates. Now, let's come to the treatment part. A diagnosed patient of GBS, if he is unable to walk unaided, especially less than 2 weeks, we should admit this patient in ICU and strictly avoid NIV in any kind of neuromuscular weakness, including GBS. We should regularly check for respiration, progression of weakness, any swallowing difficulty, any autonomic dysfunction, and we should always treat pain in all these patients. Prevent complications like in any ICU patient, prevent venous thrombosis, prevent pressure ulcers, and prevent pulmonary infections. We should start or consider physiotherapy, rehabilitation, and all these patients and their attendants need psychological help. Now, when there is a need for intubation, whenever you see a rapid progression of weakness with bulbar weakness, because there are chances of aspiration, when the patient is having staccato speech. What is staccato speech? When there is a break in the sentence, when the sentence becomes choppy, when the patient takes a pause after speaking any word, this is called as staccato speech. When there is poor cough reflex, when patient is using accessory muscles of respiration or having abdominal paradox, or when the single breath count is less than 20, the patient requires intubation. Objective assessment we can do by spirometry, vital capacity if less than 20 ml per kg or less than 1 liter, or if maximum inspiratory pressure is more than negative 30 centimeters of water, or if maximum expiratory pressure is less than 40 centimeters of water. We call it 20, 30, 40 rule. If there is 30% drop in any of the parameters over 24 hours period, we should intubate the patient. Now, ABG usually can be very misleading in these patients and may result in delay in airway control and ventilation. So we should not direct our intubation towards ABG because ABG's initial stages will be normal and hypercapnia with respiratory acidosis will be only seen when there is a respiratory failure. A single breath count test. It is the maximum measure of serial counting of numbers in normal speaking voice after a maximum inhalation. So after a maximum inhalation, you tell the patient to count. If he is able to count more than 25, it suggests normal respiratory muscle activity. If the count is less than 20, it is suggestive of respiratory muscle failure. So this single breath count, it has got a good correlation with peak expiratory flow rate, PEFR, and forced expiratory volume in the first second. So if patient is not able to count 20, it shows that the vital capacity has greatly reduced to 15 to 18 ml per kg, where normal values are 65 to 75 mils per kg. So if count is less than 20, straight away go for intubation. Now in 60% of patients with GBS, there is dysautonomia. And in 20% of the patients, this dysautonomia is very severe. You will see labile blood pressure and abnormalities in cardiac rhythm with arrhythmias. This can lead to sudden death. So if there is hypotension, put the patient in treadmill position and administer IV fluid. Always insert a arterial line if you suspect dysautonomia. Use the vasopressor with caution because there can be exacerbated response, and whenever required, start with minimal doses. If there is hypertension, avoid beta blockers and use shock acting agents like hydralazine or enalapril. Always look for bladder dysfunction, gastroparesis, ileus, constipation, and treat symptomatically. If the patient is having severe GBS, as defined by inability to walk unassisted, or there is need for mechanical ventilation, we should always start with immunotherapy. Immunotherapy consists of plasma exchange and IVIG. Both are effective and we should start them as soon as possible. Plasma exchange, that is plasmapheresis, is of greatest benefit if used within 2 weeks. However, up to 4 weeks we can use if there is a severe disease. The problem with plasma exchange is that it requires lot of infrastructure, RO machines, dialysis machine, need for vascular access and risk of infection. IVIG administration is equally effective if given within 2 weeks. In cases of IgA deficiency, it should not be used. So whenever you are contemplating the use of IVIG, check for IgA levels. Complications include aseptic meningitis, renal failure, stroke, or myocardial infarction. The GBS study group guidelines recommend exchanging 200 to 250 ml plasma per kg body weight over to 7 to 14 days in 3 to 5 treatments. In my institute, we usually give 5 treatments over 10 to 14 days. Plasma exchange in general is recommended for patients who have got severe GBS, that is, who are approaching the inability to walk unaided, who require mechanical ventilation, or demonstrate a falling vital capacity, and who have got weakness of the bulbar musculature leading to dysphagia and aspiration. IgIG is equally effective as plasma exchange, and it has become now the preferred treatment because of its relative ease of administration. You don't require a machine, and also plasmapheresis is not available in most of the centers, and it requires good venous access and a stable cardiovascular system. The dose of IVIG is 0.4 gram per kg for 5 consecutive days. In some centers, in some studies, they have used 2 gram per kg for 2 consecutive days. Now, what is the timing of immunotherapy? When should we start? Treatment is beneficial if given within 4 weeks of onset of symptoms for plasma exchange. More so if we start within 2 weeks. And also for IVIG, we should start within 2 weeks. What I have seen, what the recommendations say, that we should start these 2 forms of immunotherapy as soon as possible whenever a diagnosis is made. There is no substantial benefit of using both the therapies simultaneously. What is the role of steroids? We have seen that this is an immune mediated disease. So what we think that steroids have got role, but studies have proven that there is no significant difference in disability related outcome between corticosteroids and placebo group. Oral corticosteroids have delayed recovery, and IV methylprednisolone alone was not beneficial or even harmful. So corticosteroids are not recommended in the treatment of GBS. So we should not forget that we should institute lung protective ventilation as soon as possible in cases of GBS whenever there is a need for intubation. Then proceeding by weaning. Tracheostomy is required if the patient requires ventilation beyond 2 weeks. We should give relief of pain in almost all the cases of GBS. If there is early nociceptic pain in the back and proximal limbs, it is usually treated by NSAIDs. For late neuropathic pain, you require TCAs or gabapentin. And if the patient is on ventilator, you may have to start the opioids. DVT prophylaxis and nutrition, adequate nutrition are very important for GBS patients. Now let's discuss a case. A 40-year-old male with progressive weakness for 8 days, which started in legs, distal legs, followed by difficulty in lifting objects. There is slurring of speech and choking while eating food for past 2 days. Patient gives history of flu-like illness 2 weeks back. On neurological examination, there is dysarthria and facial asymmetry. Motor weakness is grade 4 by 5 in lower limbs and grade 3 by 5s in upper limb. Weak DTR, deep tendon reflexes are seen in lower limbs. And on single breath count, the patient is barely able to touch the number of 20. So let's see the question. Who will answer me? Which of the following is our most appropriate? Areflexia or hyporeflexia may not be present in a patient with GBS. Normal CSF findings rule out GBS. NCV EMG studies must for diagnosis. With a single breath count of 20, intubation can be delayed. Anyone who can answer me? So let's see the reflexes.
A.
Areflexia. Anyone answering?
A is the answer, sir.
Yes, A is the answer. Areflexia or hyporeflexia may not be present. Yes, this is true. While we see that most of the patients have got weakened deep tendon reflexes, that is hyporeflexia or loss of deep tendon, areflexia. But in initial stages or in some variants of GBS, we can have normal reflexes or hyperreflexia. So A is the right answer. Normal CSF findings rule out GBS. Normal CSF doesn't exclude and doesn't point towards the GBS. What we see in the CSF finding? A high protein count with normal cell count. NCV EMG studies must for diagnosis? No. GBS is a clinical diagnosis. And with a single breath count of 20, we cannot do the intubation. The normal is more than 25. If it is 20, a patient of GBS requires intubation. Anyone who wants to ask any question?
Sir, I have a question.
Yes, please.
Sir, is there any role of any interleukin antagonists in this disease?
I have not used any interleukin and I have not read about it. But there are one or two interleukins which are in research, especially the antibodies which have come in the research, but they are not recommended anywhere.
Thank you, sir.
The only two therapies which are recommended is plasma exchange and IVIG. It depends from institution to institution on the patient profile and on the neurologist which he wants to use.
And sir, another question do I have?
Yes.
If we are using plasmapheresis or IVIG, then for how long we need to keep barrier nursing for that patient? Is there any specific guidelines for that?
We need to keep barrier nursing.
I mean, to prevent infection, since the patient is immunocompromised during, there's a chance of immunocompromisation during the therapy.
There are chances of immunocompression, but barrier nursing is not required in patients with GPS. We always keep the patient normally in ICU, not in isolation rooms.
Thank you, sir.
Anyone else?
So, is there any role of hemodialysis or any special hemodialysis filters?
Only when the patient is having renal failure, we need to use the hemodialysis. Otherwise, hemodialysis is not warranted. The other filters are not warranted.
Thank you, sir. And during this disease,
because there is cytokine production will be there because of the infection. Hello?
yes,
If we are using filters for the cytokine removal, the cytokine
yes,
production will be there because of the infection. This GBS is not because of the cytokine. The GBS is because of the deposition of the antibody complexes on the nerve sheaths, nerve cells, complement activation, and recruitment of macrophages.
Okay. And is there any special attribution to any kind of electrolyte abnormalities during the disease? I mean, did you encounter any electrolyte abnormalities during the disease?
There cannot be any electrolyte abnormalities because of GBS. But while the patient is deficient in nutrition, we need to supplement all the electrolytes. We need to give adequate nutrition containing all the electrolytes.
Thank you, sir.
There is no specific abnormality per se because of GBS.
Thank you, sir.
Hello, sir. I have a question.
Yes, please ask.
Yeah, so you were talking about autonomous dysreflexia.
Yes.
Yeah, so how will you normally manage this kind of autonomous dysreflexia in ICUs? Because I have seen like they go constantly bradycardic and hypertensive, and sometimes they, yeah.
whenever you see or suspect this dysautonomia in a case of GPS, first go start with the hemodynamic monitoring. Insert a arterial line, insert a central line, and
Yeah.
constantly monitor for any changes, any aggressive changes in BP or arrhythmias. So whenever there is a, like I saw one patient who was having persistent bradycardia, we started atropine infusion in that patient. And
Okay.
as I've already told you, that these patients are very sensitive to even small doses of vasopressor. So if you see hypotension, start with a minimal dose of vasopressor. And if there is hypertension, then give short-acting antihypertensives like hydralazine or enalapril. Don't go for
Okay.
beta blockers because they have got a long duration of action. Like the
Okay.
labetalol will last for half an hour to 45 minutes.
So
Okay.
what is the dose of, atropine infusion if we need?
Atropine infusion,
Yes,
we
sir.
start at 1 milligram per hour. We start at 1 milligram per hour and we can progressively increase.
So maximum, how much can we give?
The maximum dose.
Yes, sir.
This we usually follow protocol of opioid poisoning. For GBS, there is no maximum recommended dose, but usually this dysautonomia, this goes within a 3 to 4 days.
Okay, sir. And sir, if we encounter any hypotension, is there any specific choice of inotropes that we should first use, or we can use any like noradrenaline, adrenaline? Is there any specific choice
Yeah,
for inotropes?
we usually start with noradrenaline, and it usually suffices. If the hypotension is associated with bradycardia, then you can start the adrenaline or dopamine.
Thank you, sir.
And one more question. You're talking about single breath count. If it is of 20, is there any kind of ITO criteria admissions with a single breath count, or is just for the ventilation purpose you use it?
For the ventilation purpose only.
For the
Like for
ventilation.
more than 25, the normal is more than 25. If the patient
Yeah.
is not, you will see the patient. Only this is not the only criteria for intubation. If the single breath count is less than 20, the patient will have difficulty in breathing. He will be having statecto speech. That is, he will break his sentence in between. He won't be able to speak a full sentence. So you'll see so many things. It's not just the only thing.
Okay. Now I'm just asking, is there any kind of ITU criteria for admission, or just for ventilatory purpose you
Just
decide?
for ventilative purpose. No, no.
Okay, fine. Thank you.
So during weaning from the ventilation, should we follow the normal weaning criteria, or is there any difference from the normal?
Normal breathing criteria. Normal breathing criteria. Again, the tidal volume which the patient generates, the patient's diaphragmatic activity, his cough, we all see. Like just like in any other ICU patient, we follow these.
Thank you, sir.